Good evening and welcome back to the Lipid panel. My name is Dr. Guy Mintz. I am the chair of programming for the Lipid panel, working alongside Chloe Mativi from the NLA. The Lipid panel was conceived to be a lipid clinic conference on a national scale. For those of us who are lucky to have in-house colleagues, Lipid Conference is a great way to debrief after a busy day, review diagnostic approaches, interpreting clinical findings, and generating therapeutic strategies, and coming together with colleagues. The conference is available to all of us, and we'd love people to participate or bring cases to us. So if you have any topics you'd like us to discuss or cases, please email myself or Chloe so we can bring those topics to fruition. Tonight we have a great program on women's heart and hormone effects on lipids and cardiovascular disease. Our moderator this evening is Eliot Brinton, who is the president of Utah Lipid Center in Salt Lake City. He was trained in internal medicine at Duke and in metabolism, endocrinology, and nutrition at the University of Washington. He's an associate editor of the Journal of Clinical Lipidology, a founding board member of the National Lipid Association. Our case presenter this evening is Krishna Patel. She's a second-year internal medicine resident from University of Pennsylvania. She's a researcher in Penn Medicine's preventive cardiovascular program, and we're very happy to have her joining us, and future cardiologist. We also have Brittany Katz with us, who is an internist with a special focus in women's health. She graduated from the Warren Alpert Medical School with a concentration in women's reproductive health. She's boarded in obesity medicine and menopause care. Robert Wild is our other panelist. He's presidential professor and vice chair for R&D Department of Obstetrics and Gynecology, professor of family and preventive medicine and biostatistics and clinical epidemiology at Oklahoma University, Health Sciences in Oklahoma City. He's an experienced clinician in the area of combining gynecology and preventive cardiology. He practices and teaches principles of evidence-based practice and is a national consultant in OBGYN, menopause, reproductive endocrinology, preventive cardiology, and women's health. So without further ado, I'm going to hand the program over to Dr. Brinton and our elite group of panelists and case presenter. Thank you.
Excellent. Thank you so much, Guy. This is going to be fun, I think. So Krishna, please present this case to us. It's an interesting one, but it's also a think down the middle of the road one. It's not an unusual case at all, right?
Yes, absolutely. So let's get started. MP is a 52-year-old Caucasian G3P2 female. She's seeking treatment for a high coronary calcium score and also for new menopausal symptoms. Her presenting symptoms started about 6 months ago, and they include hot flashes, night sweats, sleep disturbance, brain fog, and dyspareunia. She's also noticing some weight gain in her abdomen. Her past medical history includes hypercholesterolemia. She has coronary artery disease. Her CAC score was 440, placing her in the 99th percentile. She has hypothyroidism as well as hypertension, both of which are controlled, and no history of any known blood clots, DVTs, or prior strokes. And this is despite her prior oral contraception. Her past surgical history is unremarkable. She does not have a prior hysterectomy. Family history includes high blood pressure, hypercholesterolemia in her brother, high blood pressure in sister, hypercholesterolemia in father, and high blood pressure in her mother. She has no family history of any known osteoporosis, no malignancies. Her current medications that she's on include atorvastatin 20 milligrams daily. She is also on Synthroid 100 micrograms daily, diltiazem 30 milligrams daily, and metoprolol tartrate 25 milligrams twice daily. Social history, she has never been a user of any tobacco or marijuana. She drinks 1 to 2 drinks of alcohol per week, and she's physically active. Her vitals, her blood pressure in clinic is 118/76. Her height is 5'6", weight is 161 pounds, putting her BMI at 26. She has a waist circumference of 36 inches, and some other labs, including her TSH, which was normal at 1.4, her fasting serum glucose is 98, her hemoglobin A1C is 6.4, and ALT, AST 20 and 15 respectively. We have a lipid panel here. 1 year ago, when she was in her premenopausal state, her LDL-C was 140. 6 months ago, when she was placed on atorvastatin, it came down to 75, and currently it's at 80. Triglycerides fasting a year ago were 175, came down to 140 on the atorva, currently sitting at 150. And her HDL-C was 50 about a year ago, 52 on medication, and then 48 currently. Her lipoprotein little a was checked 1 year ago. It was at 80 with an expected rise to 96 on the atorvastatin. And this is just to go over some expected physiologic changes that occur during the transition to menopause. So we do expect to see an increase in visceral adiposity, as well as LDL-C triglyceride levels, and overall just apoprotein or ApoB, as well as systolic blood pressure. And we do see a decrease in HDL as well as lean muscle mass.
Okay. Thank you so much, Krishna. Oh, let's see. You want to do this one also? Go ahead, please.
I was going to have you go over the.
Oh, okay. I'll do this. All right. So anyway, this is a very interesting case. She's very typical. This is, a menopausal woman comes with menopausal symptoms, of course, and she's kind of average in many ways, although you notice that she's got this calcium score of 440, which is sky high. So her lipids were a little high, LDL of 140, Lp(a) quite high at 80. So that's, for milligram per deciliter, that's more than double upper limit of normal. And presumably that's what's driving her very high coronary calcification. And we don't have that listed on this slide here, but that is something obviously that women can get, is they can start to get the calcification, which men may have at an earlier age, and women tend to get this after the menopause. She ends up having it a little bit beforehand. So what do we do? She's a high-risk woman in terms of cardiovascular disease. We're very concerned about that. We've got her lipids in reasonable shape, but maybe not where we want them to be yet. I don't know. So the question is, does hormone therapy reduce hot flashes, vasomotor symptoms, and other things, other symptoms of the menopause? And of course they do. This is something we tend to forget sometimes if we're not focused on menopause. But this study, which came out last year from the Women's Health Initiative, shows dramatic improvement in the vasomotor symptoms. And you can see this in the women who were randomized at either in their 50s, their 60s, or their 70s, either in the estrogen alone trial on the left or the estrogen plus MPA trial on the right. So very nice reduction in symptoms. And then the question is, well, what else happens? They did look at cardiovascular events in this group of women, but remember, this is an unusual group because they tried to exclude these women with menopausal symptoms from the trial. They didn't want women unblinded, right? If you're doing HT versus placebo and women have symptoms, they're going to know if they're getting the placebo or the real thing. So this is a very small fraction of the WHI trial, but it's interesting data. It came out fairly recently, and I think useful for us to consider. This just shows the data from that trial, and it's a little hard to read, but the point is that there was a much better response in terms of CVD risk, both in the women that were in the estrogen alone trial and also those who were randomized at a younger age. We're going to talk about some more data on that regard in just a minute.
I just want to add one thing in here. I think the original take home from the Women's Health Initiative was it was stopped early because of cardiovascular risk, stroke risk. And so this study is looking back at that data and reanalyzing it and showing in the appropriate women, if we actually look at this data, that was a false conclusion that we drew. And so that's why this study was so exciting.
Yeah, thank you. Thank you. Yeah, we didn't see evidence for an increase, and especially not if we're focusing on the younger women. We'll get back to the full data set in just a minute, but thank you for making that point, Brittany. So lipid and glycemic effects of oral hormone therapy. And you can see in the top with just estrogen alone, and then the bottom, similar pattern actually with Premarin plus Provera. you see that there's a decrease in LDL, a decrease in Lp(a). Of course, we're not sure if that's helpful yet. We don't know that lowering Lp(a) works, but also improvement in various glycemic parameters and a fairly similar pattern with E plus P. So we know from the overall picture, the overall data set of WHI, there are lipid improvements, and we can keep those in mind. I mean, hormone therapy is not primary therapy for lipids, but it certainly can be helpful as we're using other agents, as we are in this case. She's on a statin. Let's see if we can get the slides to move. Okay, so we now have an audience response question, and I'll go ahead and read this to you. The patient agrees to start hormone therapy, and she is enjoying excellent relief from symptoms. For how long would we continue this? Do we want to plan to continue her for a year or two, up to 5 years, no longer? Should stop as soon as symptoms are manageable, or should we consider even longer term use? What do you think? So Chloe, do we have the vote? Oh, there we go. So a small number of us say 1 to 2, a third of us say up to 5 years. Some are saying, well, as soon as you possibly can from the symptoms, and then 40% say indefinitely. That's interesting. So a pretty good spread, and there, of course, is not a consensus about this. So thank you for that vote. I appreciate that. Let's see if we can go on to the next slide now.
We've also got a good question in the chat that I want to draw attention to because it relates to our last slide about the LDL changes.
Sure.
Someone questioned, I have a patient with a baseline LDL 118 who came to see me due to elevated calcium scores. She then started on estradiol, progesterone, and testosterone, and her LDL increased to 220 with ApoB 146. No clear secondary cause for the lipid elevation. Could the hormone therapy explain the jump in the numbers? And we saw from the last few slides that the estrogen and progesterone would not do that. Testosterone has been known to do that. Bob, if you want to comment a little bit more on that.
Well, we don't know how much testosterone she's getting, how it's being given, but in general, yeah, see that depending on how it's used or abused in terms of amount and indication of it.
And one interesting phenomenon that we've seen now in several studies with testosterone is that there tends to be an increase in CVD risk for the first year or two, which is also tends to be the case with hormone therapy in women. In fact, we're going to show some of those data in just a minute. So thank you, Brittany, for that comment. Yeah, I don't know that we can explain it.
I'd be curious to see the testosterone level in that patient too.
Yeah, you've got to be super careful. I mean, it's off-label, of course, to give testosterone to women. Women who go through the menopause will have a drop in testosterone levels. And so super low dose testosterone is something that a lot of us do. It tends to make the women feel better, but we've got to avoid masculinization and other adverse effects.
I think it's important to know that in the United States, it's approved for hyposexual desire.
Okay,
but that's about the only indication.
Well, and that's one reason that we might give it. You can give it for other reasons, muscle mass.
I'm just saying approved. So it's different, let's say, in Australia, where it's more liberally used. So there's some uniqueness in North America.
Yeah, it's not wrong, but we've got to be very careful with the dose for sure. Okay, so hers is a very interesting trial. Smaller trial, came out before WHI. But it has some very interesting information regarding Lp(a) and the possibility that Lp(a) may make a difference in terms of response to hormone therapy. These are data from the overall trial. It's a group of women who had prior cardiovascular disease. They were recruited in their mid-60s, interestingly, on average. And you can see on the left that there is a higher risk of cardiovascular arrest during year 1 of hers. So the women taking HRT or hormone therapy, this is E plus P only, they have a much higher risk. It's 50% higher. And then years 2 and 3, they kind of match. And then you go out to years 4 and 5, and the curves are reversed. So later on, after this initial increase, hormone therapy is actually associated with a decrease in cardiovascular events. That's quite interesting. And I think it's even more interesting to look at the data with statins. Those women who happen to be on a statin, which was a large number, nearly half, had fewer events. You see it's actually a stat sig relative hazard there of 0.79, so a 21% lower rate with concurrent statin use. Notice that the VTE is interesting. This is E plus P orally, which gives you, of course, a big increase in VTE or thromboembolic events. And notice that with statin use, that is lower actually. It's not necessarily lower than it would be with placebo, but it's lower than it was without a statin. And then we've got no first-year increase. So that first-year increase is gone. The overall total across the trial is lower, and a suggestion of a possible mitigating effect for venous thromboembolism. I don't know that that's well established, but that's kind of an intriguing thought. This is now looking at the data by the quartiles of Lp(a) levels at baseline. The median was right kind of at the upper limit of normal, 25. The upper limit for milligrams is 29. And if women were in the third or fourth quartile, so above the median, notice that year 1, there was a little bit less of an increase in events. Years 2 through 5, it was clearly lower. Whereas the women who had an Lp(a) below the median, meaning within the normal range, they actually had a clear increase in year 1, and years 2 through 5, it came down a little bit, but was not decreased. So we're not sure that this means what it suggests it may mean, which is that lowering Lp(a), which they did have, these women with higher Lp(a) had dramatic drops. We're not sure that that is actually why we see this, but this is an interesting finding and food for thought. You know, we're waiting for data, of course, on the medication trials for Lp(a) lowering. That's much more dramatic. I mean, this is a reasonable drop, but more in the range of what you see with a PCSK9 rather than with anything more effective. So let's ask a quick question about dose of estrogen. These are observational data. We don't have good dose data in randomized trials, but in the Nurses' Health Study, a very large observational study, you see that both at 0.625 and 0.3 of conjugated estrogen, there was a roughly 50% lower risk. And of course, the question is, does that apply going forward with proactive treatment? And of course, we're not sure. These are observational data. But look at the following finding. If you're looking at stroke with those same 2 doses in comparison, you see something very different. Stroke is clearly increased at a standard dose of conjugated estrogen or Premarin, 0.625, but it looks like it may be decreased if you go to half dose. That's an interesting thought. So should we consider lower dose, especially with the oral agents? The answer is a resounding maybe. We have some suggestive data here that I think are worth considering as we figure out what dose might be appropriate and whether or not we can reduce a dose after a woman has been on hormone therapy for a while. What about the time of initiation and also duration of therapy? Well, let's look at initiation. This is now from the full data set of WHI. Brittany mentioned earlier that we had that small subset that had symptoms, and they had symptom relief. Here we are looking at estrogen plus progestin. Let's look first at estrogen alone on the right. You see that there is clearly a reduction in cardiovascular events in those women who were randomized and entered the trial before age 60. And then it goes up and goes up further. So it never actually goes up significantly, but it is no longer decreased, right? It just goes from a decrease to a neutral effect. Now let's look at estrogen plus progestin. This is conjugated estrogen plus medroxyprogesterone, a synthetic progestin. And you'll see that in those younger women, there was no longer a significant decrease, although it wasn't increased. And then you see a statistically significant increase in the women more than 20 years out, and there's a trend upward in the intermediate group. So there is a suggestion that maybe medroxyprogesterone might somehow get in the way of a favorable effect that we have if we start estrogen alone in younger women. Of course, if a woman has not had a hysterectomy, we have to give her progestin. But this is medroxyprogesterone, a synthetic estrogen or progestin. And the question is, what about those other progestins? And the natural micronized progesterone has very little, if any, adverse effect on CVD. So that's an interesting workaround that we may have as we're going to patients who will need a progesterone. I think we don't want to use synthetic progesterone. That's just not a good idea. And
we have a related question in the
show that.
chat. Bob, I'm
Please,
going to
go
pose
ahead.
this to you. The WHI saw more events with estrogen and progesterone in older women who had onset of menopause some years before starting hormones. Timing makes a difference. I guess it's more of a sentence than a statement, but a statement than a question. But can you comment on that?
There's been a theory of timing, which is permeated early versus late. It'll continue to be controversial. I think what I go by is the indication for hormone treatment is menopause symptoms. And that actually drives oftentimes issues regarding dose and or route and or amount given. So putting that in the equation is important in terms of tailoring given the patient. I go by the belief that it's highly unusual for a person to go along and all of a sudden start having hot flushes. In general, most people, when they transition through the menopause, you can divide them into three basic groups. There are a few that just skirt through and have no symptoms whatsoever. There are many who go through, even before menopause, the definition 1 year without a period, and then they have symptoms that are challenging for them for about 5 years, and then they improve. And there are the other group that tends to fall into the fact that they're miserable their whole life. And those are the people that you have to tailor to understand and address their given symptoms. And that's a balancing act, understanding risk and benefit and dose and variety and specifically what the symptoms are. We're concentrating on cardiovascular disease. After all, it's the most important focus for us here, and good reason. But it's kind of for me, it's a global entire picture of management.
Those are great comments. Thank you, Bob. Brittany, do you have anything to add to what Bob just said?
Yeah, I definitely agree. I've had patients that they've run the gamut. The symptoms burn out quickly, but I did have a 70-something-year-old patient tell me a few weeks ago she has hot flashes 3 times a day. And it's a different conversation when we're talking about hormone therapy initiation at that age. But the current data suggests that once we're after 65, now the Menopause Society is saying after 70, maybe the risks of initiation at that point outweigh the benefits. But again, if you have a woman who is like unable to live her life, then we need to manage those symptoms and just risk optimize the best way that we can.
I'm reminded of my patient at the VA in a wheelchair who's been on her estrogen and been told by 4 or 5 doctors she's got to get off. And she looked at me and I says, no, you don't. Your symptoms and you're doing well, good for you.
Well, and let me just add something here I think it's important to note is that what was done in the WHI, and one of the reasons it's so controversial, is they took women who generally did not have menopausal symptoms at all. And they said, well, if you're in your 60s or your 70s, let's see what happens if you start hormone therapy for no particular reason. And that didn't go well. There were a lot of problems. I mean, you see them on this slide. There were a lot of other problems that were much worse in the older women. This is coronary heart disease, but also stroke was very strongly age-related. And one thing I'd like to point out, and this is something that people never talk about, is that starting estrogen at age 70 is probably very different than continuing at age 70 if you've been on it for 20 years. And nobody really has addressed that in a clinical trial. And it hasn't even been very well addressed, to my view, in observational data. So we talk about estrogen or hormone replacement at age 70 or 80, as we've been discussing. That, to me, is not necessarily the same as what we saw in Women's Health Initiative, because these women were starting it for the first time. Very few of these women had taken hormone therapy at all, ever. And so starting at age 70 is, to me, very, very different than saying, hey, you're doing well, you need this at age 70, let's continue. Continuing is different than starting. And I think that's a really...
For us to get the kind of inference we needed, we need large numbers. We have population studies. We have clinical trials, we've got observational studies. But virtually nobody's truly average. It's an individual treatment strategy. And there are nuances. And I think what the discussion is coming up with is that certainly is true. We can't give up our clinical judgment of focusing on what our patient really needs, not putting her at unreasonable risk, but also can accommodate it to.
Yeah. Well, certainly the reason that people are nervous about that 75-year-old woman continuing estrogen is the data we're looking at here. And to me, that's a dangerous conflation of continuation versus initiation, and something that we don't hear discussed often enough, I don't think.
And we have another question that is really,
Okay.
we're going to come to. I just want to mention it. Someone is asking if there's a difference between micronized estrogen and the events seen with micronized estrogen and conjugated estrogen, and we will address that. So I'll just leave that as a teaser.
That's a very, very good question. Thank you for asking that. Let's make sure we address this later. So here, so as many of you have heard in medical school lectures, the classic situation where randomized clinical trials are correct and observational studies can be incorrect. Well, the classic is hormone replacement, right? I mean, look at the WHI, which was so different than the observational studies. Okay, well, that may be just the difference between randomized and non-randomized. But let's look at these data. Let me focus your attention here on coronary heart disease in clinical trials here on the left and observational studies on the right. And what you see is actually a rather similar pattern of the relative risk as you go through the different years of follow-up. So less than 2 years of follow-up, it's up by 68% in the clinical trial, it's up by 12% in the observational study. Now let's go to 2 to 5 years, drops from 68% elevated to 25% elevated, drops from 12% up to 5% up in the observational studies. Now let's go to the later, and you can see that the pattern continues. And that is true not only for coronary heart disease, but also for stroke. It's like, wait a minute. So what about duration of therapy? You know, a lot of the data from WHI was concentrated in the younger, in the earlier period of the study. And once you go to the later period of WHI, that risk drops, just like it did in hers. You saw that graphically, how the risk went down over time. So that's kind of an interesting problem. And then another problem is that even though the dogma is that we have to discontinue just as quickly as we possibly can, again, conflation of continuation versus initiation, there haven't been any trials of discontinuation. We don't have any randomized clinical data. So let's look at this now just a little bit differently. Let's look at just more than 5 years in a clinical trial. That risk is trending downward. It's not stat sig. But for coronary heart disease and stroke, you've got a rather strong trend downward if you're going to treat somebody more than 5 years, even if you started them at a later age. So that's kind of an interesting thing that, again, we don't tend to consider, that discontinuation, which has been the mantra ever since the WHI, is not grounded in data. And of course, you see the individual patient who says, you know, I will not let you take the estrogen from me. And of course, patients should have that option of continuing if they wish to. And there are some data that look at discontinuation. These are data from a Finnish cohort. Of course, it's not randomized, but take a look at the data here where cardiac death is up within, if you've got exposure either less than 5 years or greater than 5 years, you've got a striking increase, more than a doubling of risk of cardiovascular events during the first year. And beyond the first year, you've got also a continued increase. So you're seeing an increase in these women who just stopped. I mean, maybe they were told to stop. We don't know exactly why, but they stopped, and look at what happened to their risk. That's cardiac death. Let's look at stroke death, the exact same picture. So is it benign to take somebody who's been on estrogen for a year or 2 or 5 years, and we're just going to stop them because we have to stop them? Well, I'm not so sure. And of course, it's complicated because there are reasons for stopping and there are reasons for not stopping. And these data do not control for that. So this is an open-ended question. Any comments on the question of discontinuation from either Brittany or Bob?
Well, we actually have a question in the chat that relates to this. One of the gynecologists at my clinic, who's NAMS certified, recommends stopping HRT when ASCVD risk calculation is over 7.5%. Are any of you NAMS providers and know if that's an official recommendation? That's not a NAMS official recommendation, but I definitely can see that happening. I think it makes people nervous when the cardiovascular risk is high, and it's always something we've been taught to consider before initiating hormone therapy. But we've also been told, well, make sure a woman has her mammogram, and we have to discuss breast cancer risk. And the FDA is removing that from all estrogen products starting in November. We're seeing all these black box labels fall off of these estrogen products. So we're seeing, this is the data proving it, that no, you don't have to, that now that doesn't, it doesn't replace the fact that you still have to manage her cardiovascular disease risk outside of that. If she needs a statin, she needs a statin. The hormone therapy is not going to prevent that, but the higher cardiovascular risk does not eliminate the potential for this woman to stay on hormone therapy.
Thank
the
you,
way
Bob.
the way I respond to that is you have to focus on her needs. If she's concerned for vasomotor symptoms, she needs to be treated for it. Her LDL is not on target. Her lipoprotein A is not on target. He knows what those should be. We have good tools to manage them. I think we can go ahead and work on all fronts to optimize it.
Yeah, we definitely, I mean, we're lipidologists, so we're going to treat their lipids, and we have very effective tools, frankly, more effective than hormone therapy. But hormone therapy can be adjuncts to statins and other treatments for lipid disorders. And my take on this is to be more aggressive in managing these risk factors in a woman who is on hormone therapy. And then the big unknown is exactly how does this shake out depending on what kind of symptoms the woman is having at what point in time. And we just don't have good data. I mean, the observational data, of course, are voluntary discontinuations. But was this because the physician said, we need to stop this, your risk is above a certain threshold? Or is it because the woman was really feeling great and didn't have vasomotor symptoms? We don't know. There's so much that we do not know about this. And it's really, I think, problematic, frankly. One question.
The symptoms are very well understood. That is specific. And a lot parades like it. So I understand some of the concerns. The question is what's real and what isn't. We'll all get into that. There's no reason to leave her miserable if she really is miserable. I think we should focus on getting the lipids under control.
Well, I think we all wish we could have another $700 million of NIH money and go back and redo WHI with a more clinically relevant population. You know, forget the women that have never had symptoms and they're now 65 or 75, and focus on the questions that are at hand, which is somebody comes in with symptoms, they're presenting, you know, right after the menopause. And then the question, of course, is how long to continue? You know, should we arbitrarily discontinue? Should we have a program for knowing how to discontinue? And if we do have that program that's maybe based on symptoms, how does that impact on CVD risk and other things like osteoporosis, you know, diabetes risk, other things that are maintained at a lower level if we continue hormone therapy? And if you stop hormone therapy, then those benefits seem to go away. So it's kind of an interesting question. Go ahead.
Comment came, why not use Bioza and get her off HRT? Yeah, that's an option. But what's the indication for the HRT for her? What are the true symptoms? Is she sexually active? Does she have vaginal dryness? Does her mood really improve? Is she willing to have the monitoring that are required for that option? Does she have the means to handle it? All those get into appropriate choices.
Yeah, that's a great question. Thank you. Thank you, Bob. The elephant in the room, to my view, whenever I see a patient like this, is breast cancer. And of course, thanks to the FDA, we're now kind of unpacking that a little bit. But I want you to be aware that in the WHI, there was a 24% increase, just borderline stat sig, in the E plus P trial. So breast cancer was on the cusp of being statistically significantly increased, a 24% increase. And that's what caused that trial to end, basically. That the E plus P trial ended early for that reason. So then along comes the estrogen alone trial 2 years later. And what happened to breast cancer in that trial? Well, nobody knows because nobody was paying attention. But it turns out there was a 23% decrease in breast cancer in that trial. It's like, wait a minute. Breast cancer goes up with estrogen plus androxyprogesterone, goes down with the same estrogen, this conjugated estrogen, without MPA. So my conclusion is that MPA is a pretty strong agent for causing breast cancer. We have other studies that show this. And micronized progesterone, the natural progesterone, has very little, if any, effect. So the breast cancer thing, I think, is very important. And a woman who has a uterus, we have to treat with a progesterone. But I think nowadays with micronized progesterone, we don't have the same concern that we did have in the WHI trial data. So, Krishna, let's go back to the case here.
All right, so just a brief summary. So MP, again, 52-year-old Caucasian female, referred for high-risk primary CVD prevention, high LDL-C, high lipoprotein little a, and many moderate to severe postmenopausal symptoms. Past medical history of hypertension, hypothyroid, no blood clots, DVTs, no hysterectomy, and family history of high cholesterol, high blood pressure, no known CVD clots, no known cancers in her family history. So update after starting oral conjugated estrogen at 0.3 mg per day and micronized progesterone. She has good control of her menopausal symptoms on these agents. She has more energy, and there's no adverse effects of the atorvastatin that she's on, which is 20 milligrams per day. And just updated vitals. Her blood pressure remains controlled, 118/76. Her BMI is 24.4. Waist circumference is 34 inches now. Labs, her fasting serum glucose is still normal, 88. A1C came down to 6.1. ALT, AST remained normal at 18 and 13. And her lipid panel, so LDL-C has gone from 80 on the Atorva 20 before starting her hormone therapy, now down to 65 about a year later. And triglycerides were 150, currently sitting at 170. HDL was 48, currently 58. And her lipoprotein little a, which was 113, is now 91.
Okay. Brittany, I know that you are concerned about the, and many people, not just you, of course, are concerned about the tendency of oral estrogen to raise triglycerides. I'm just curious about your comment about this case.
Yeah, it's definitely something we see, and it's something that it's not just the oral estrogen in this moment of her lifespan. I see women across their lifespan. I see this around pregnancy. So it definitely is something that gives us pause with the oral estrogen. What we don't know, like this does not translate to cardiovascular risk. It makes people nervous to see this jump, especially because it can be more dramatic than this, but it doesn't translate to an increased cardiovascular risk. But we don't see this with transdermal estrogens. And for women, this woman did not have a history of DVT or clot, but for women who have a higher clot risk or factor V Leiden, transdermal estrogens don't increase that risk of blood clots. So there is some thought that could the transdermal estrogens be a little bit safer maybe for the higher risk women, probably in terms of blood clot, yes, but I don't think necessarily in terms of cardiovascular risk, although we just have to monitor this and make sure that it's, 150 to 170 is one thing, but if we're talking about someone who's much higher and poorly controlled high triglycerides, that wouldn't be a good candidate for an oral estrogen.
Thank you. Bob, what do you think? Do you have any comments about oral versus transdermal or patch, and any other comments about this case at this point?
Well, I think Brittany covered some concerns of when triglycerides are high enough that estrogen causes pancreatitis. It really can. And the issue is, where's that cutoff? We like numbers. Numbers like this, I think most of us are not too worried about. He starts coming into 500 or 600 or 700, you think, whoa, let's start backing off a little bit to think about different options. In general, I think because of the mechanism of how patches work, I think that they have theoretical advantages, but there are a lot of practical problems too. About 20% of my patients don't handle them very well. For one reason or another, they can't do it, or they get reactions or whatever. So I think there's certainly patches are an armamentarium. I think the issue is what are her symptoms and what is she most compliant with? What works for her? what's affecting their life, and how does it affect their mood? All those things are involved. Some people do not do well on oral Premarin, they weep. And you switch them to an estradiol and they'll do fine. So we know that. We know what there are at least 4 families of cytochrome P450 in the liver, and all of us have different variations and we metabolize things differently. And just my plea is just listen to your patient. We have lots of tools. Be on target for controlling symptoms and don't put them at undue risk that isn't necessary. But my gosh, we have great ways to make people feel comfortable. Let's do it.
Yeah. Well, I think I love what you say. We've got a lot of tools, and hormone therapy needs to be individualized. And we want to have a discussion ahead of time. What do you want to try first? And then be willing to go through a period of trial and error. As you point out, sometimes women may start on a patch, may not do well, may start on oral, may not do well. Let's be willing to backtrack and go to something, because we're talking generally about reasonably long-term treatment, at least a few years, if not longer. And we've got to be prepared for that.
And Eliot, I just want to draw your attention, and maybe you can comment about the lipoprotein little a, because we see that it improved on the atorvastatin, and then it came down with the oral estrogen. So maybe you can comment a little bit about.
Yeah. Well, thank you. This, as you know, remains largely an evidence-free zone. We do have data from the PCSK9 trials. The 2 main trials, Fourier and Odyssey outcomes, both showed that people with higher than the median Lp(a) in those trials tended to have more of an Lp(a) drop and more of a cardiovascular event drop, similar to the HERS trial. Now, is that definitive? We're not sure. These are post-hoc analyses, but it's suggestive. And so, but then the question is, well, first of all, should we worry about the increase in Lp(a) with a statin? I think somewhere more than 99% of us would probably agree that we don't worry. Statins are terrific. And if the Lp(a) goes up a little or doesn't, we know for a fact that statins still work in folks with high Lp(a). We do know that. So I don't think that's an area of controversy. But there's a suggestion here, but we don't know. We're waiting for our first data from our first trial of a medication to lower Lp(a). We know that it works very nicely. We know that Lp(a) can be treated very nicely with the one FDA-approved indication, which is lipoprotein apheresis. Now, that's not practical for large numbers of people, but the data are really very impressive, that risk goes down dramatically with a high Lp(a) patient who has prior cardiovascular disease and is treated with apheresis on a regular basis. So we know that much. Medications we don't know. The PCSK9 thought is there. Interesting data. Smaller data set with HERS. Again, interesting data. Where there's so many unknowns with Lp(a), I think it's really hard for us to go further at this moment. But let me just suggest something. Bob was talking a little bit about this, and Brittany, you mentioned it too. The triglyceride elevation is fairly consistent in the sense that most women who go on an oral estrogen will have some increase. The average is actually probably around 20% in a recent meta-analysis, which is not much. But let me suggest that if either a woman comes in the severe hypertriglyceridemia category, which is triglycerides above 500 milligram per deciliter fasting, if she comes in at that level, I'd be very conservative, very hesitant to use oral estrogen, even at the lower doses that we tend to use in hormone replacement. Or another thing is if a woman gets above 500 on an oral estrogen, that would be concern, and I'd either try to treat the triglycerides or maybe back off on the oral estrogen. So may I suggest a 500 milligram per deciliter cutoff? I don't think we have good evidence for that, but we know that above 500 is where we really are concerned over the short term for high triglycerides. And you can see women who start out, say, at 600 and they can go to 1600 on hormone therapy, and certainly can with oral contraceptives. So be aware of where you're starting.
There's some fun questions here in the
I think we have an audience response question next,
right.
And then we've got about 10 minutes left with some good questions coming up.
Let's do audience response next.
So
can we do that, Chloe?
I'm sorry, go ahead.
It's basically the same question. So given our discussion, does anybody want to change their mind about the question of how long you want to suggest to this patient that you continue? Of course, you're going to have to follow up with her and see what happens in the future, but any thoughts about your initial suggestion of how long to continue? We should have some nice music, right, while we're waiting for the votes. Okay, looks like we've gotten people that were going really short, not so short, and a few more people indefinitely. Okay, well, we've moved the needle a little bit. Is that right? Is that wrong? Well, we're giving you a lot of controversy here, but hopefully some data behind the controversy that lets you pick what you're doing, what you think there. And let's see. Should we go ahead? Let's go ahead and take some more questions from the audience. We've got some time. We've got a summary slide to go over in just a minute, but let's take some questions right now. Brittany, do you want to read those to us?
Let's see, we've got why not use transdermal estrogen due to the increased clot risk seen with oral estrogen? Why would you use the oral estrogen? Why would you use the oral estrogen to avoid that? Or why would you use the oral estrogen and try not to avoid that altogether?
Any comment on that, Brittany?
I think a lot of it has to do with what works best for that woman. Like Bob was saying, like, you know, people react differently. We see that all the time with other hormones, Synthroid, brand versus generic. People react differently to different hormones. What are we trying to accomplish? Does she need continuous hormone therapy, cyclical hormone therapy? I think a lot of that has to do with patient preference and what symptoms we are managing and how she tolerates. So my personal practice is I often will start with transdermal estrogens as my go-to, but if they're not working for a woman or we need cyclical therapy, the oral estrogens tend to be easier for cyclical therapy.
Bob, your comments?
I think she covered it well. There's some other really interesting questions that we have to get into.
Okay, we're going to get some other. Let me just add a comment here. A lot depends on any perception of baseline risk. You know, if a woman has had clotting on oral contraceptives, I think oral hormone therapy is very dicey. I think if she's concerned about DVT for whatever reason, even if she's never had it, as Brittany points out and Bob has said also, it's very much patient specific. And the other thing is that the risk of VTE does go down with longer therapy, and it tends to be much flatter if you have to have a patient on statins. And most of my patients at the age of the menopause, I've got them on a statin anyway. So, and especially if I'm going to use hormone therapy. Let's look at some other questions, please.
What if a patient on transdermal estradiol and progesterone continuous leads to bothersome vaginal bleeding despite being a safer option than oral estradiol? Bob, I'll let you take that one.
You have to pay attention. In general, the uterus, everybody's individual. The way you give it makes a difference. The ratio between how much estrogen you're giving and progesterone or progesterone makes a difference. So depending on the titration of symptoms, you do have to be very careful about endometrial lining. We now have great tools. We have ultrasound that can show a super thin endometrium, makes us a little more comfortable because the definitive way to handle abnormal bleeding is with endometrial sampling. And then the person who we're not sure that endometrial cancer could be there, we're bound, determined, we have to find out. So I have no problem switching and optimizing in order to control her bleeding. That usually can be done by looking for adjusting the amount of estrogen in relation to progestin or progesterone. The recommended dose, it tends to work for most people. For progesterone, is 100 milligrams if you want to give it every day. With estradiol, for example, at 1 milligram. And for cyclic, it's 200 for 14 days. And surprisingly, some people want to have a scheduled menstrual bleeding. Most do not, but those are all recommended options. In general, when the progestin is too high for the amount of estrogen, sometimes you can get progestin breakthrough bleeding. And you have to be alert to that. And endometrium, usually by ultrasound, is super thin. And you have to adjust the amount of estrogen to the amount of progestin bleeding. You can't ignore the bleeding. You have to kind of figure out why it's happening.
Well, and one thing, you mentioned this cycled progesterone, Bob. In a woman who, for whatever reason, is just having a terrible problem with breakthrough bleeding, it's generally better for them to do it cycled, at least for many cycles, if not a year or two, as the endometrium will gradually atrophy, because it's obviously better to have predictable bleeding than unpredictable bleeding. So the
Yeah,
cycling can have a use.
yes, cycling can be used, and scheduled bleeding is certainly more reassuring. In general, the reason that some people like some of the synthetic progestins is it's more potent as a progestin for the endometrial lining. So, for
But I don't
example,
think oral versus transdermal is enough of an explanation for why that woman's having irregular bleeding. I think you have to figure out what it is that's causing it. Is it that she shouldn't be on continuous? She should be on cyclical? Does she have a fibroid that's bleeding? But I don't think you can explain that away with just saying, oh, it was better on one versus the other.
Yeah. Well, and as Bob mentions, you have to go to ultrasound.
you have
Refer to a gynecologist if you need to, because ultrasound is such a powerful tool to tell what's going on, like fibroids or whatever other cause.
This
Okay,
is an
another
interesting
question.
one. Is there any interest in putting a woman who otherwise doesn't have a statin indication on a statin for the first year of hormone therapy, given the risk is highest then?
The quick answer is we don't know, but the longer answer is that's what the data to me suggest. I mean, statin therapy is fairly low risk, especially if you go with lower doses. So my answer would be yes, but Brittany and Bob, what do you think?
I would target her LDL to keep it under control for what it should be in the menopausal range. And usually that means a statin to keep it down there. And then we're learning more and more lower is better for LDL. Same for women, same for men. So don't neglect the preventive cardiology part of what you're targeting here.
Yeah, we have to go with the evidence here. And I hesitate to say this in a room full of lipidologists, but statins have their bad side. And so we can't just blanket put a woman on a statin just because of hormone therapy if there's absolutely no reason to. But if she meets criteria, she should be managed before initiating the hormone therapy. That's a pressing need.
Yeah, yeah. Yeah, and I wouldn't, if somebody has a baseline LDL of 40, I don't know that I'd put them on a statin. That seems to be overkill. But of course, so many people, have LDLs in the 70 to 110 range, and it's maybe not a compelling case to use a statin, but a low dose of statin in those cases can be very helpful. And, I would find it reassuring, but you're right, Brittany. Statins are not 100% benign. There are patients who get symptoms. There are a lot of patients who stop statins without telling us, and we've got to make sure that we're not wondering why the patient is not responding to a statin that they've stopped taking just on their own, right? A lot of patients do that.
And then they move on to somebody else.
Oh, yeah. Well, we've got to be attentive to statin concerns. And there's statin reluctance. Patients have never taken a statin, but they read on the web and they read that it's bad. And we need to address that and share decision making. We can talk to them about it. And then, of course, if a patient has experience on a statin and they're convinced that it's from the statin, we can try a different dose, different agent. But yeah, statin therapy is not 100% benign, and it's not for everybody, even if you're a postmenopausal woman.
All right, Bob, please comment on weight loss and inch loss with hormone therapy.
In general, over time, hormone estrogen will help with the challenges of weight gain in general. If somebody's nauseated with estrogen use, that's a different question. Height can be halted, the loss that normally happens in our skeleton, because trabecular bone at the time of menopause transition drops over the next 7 years without estrogen. Putting somebody on estrogen can halt that problem. So being alert to what's happening in the skeleton and the body and body shape, albeit it's not dramatic, it's still there. But as you know, weight is a challenging, complex problem. It has to do with everything you know about weight challenge. It's obesity.
I think a lot of women think hormone therapy is going to be this magic bullet, and it certainly does not lead to the 25 pounds of weight loss that people would wish it would. And actually estrogen with the bloating, when you initiate it, it can increase appetite a little bit. It can increase breast size initially while you're adjusting. So sometimes women will gain weight. And so I think it's important we set that expectation that, listen, this is not going to be the magic bullet and help you lose weight, but over time, it's going to restore the physiology that potentiates weight loss. You'll be sleeping better. You'll have more muscle mass building, and but it's not going to do everything.
Pay attention to breast soreness. It can be a symptom of menopause transition before estrogen, which is physiologic and common and normal. But also breast soreness can be usually adjusted to, for most people, usually within about 3 months, it's gone. If you explain that to them, as is the nausea or even breakthrough bleeding started. We need to help people understand it takes about 3 months to begin to see some kind of adjustment. There's no accident. I try to bring people back, many of us, at 4 months, because if it's still persistent, then you have to start to change. And when you change something, there's always an upside and downside, whatever choice you make.
Well, and one thing to add here, I mean, the WHI has lots of problems, but it showed rather convincingly a reduction in new onset diabetes and a reduction in the eventual increase in central adiposity. And, you know, we have other ways of dealing with that, but it's pretty hard sometimes to get insurance to cover a weight loss drug, as I'm sure Brittany sees in her obesity clinic. So it's not the magic bullet, but if it can help us with the visceral weight gain, which is so problematic from the standpoint of metabolic syndrome, I think that's helpful. And the question is whether or not transdermal does the same thing. And I think it's going to be an individual thing. There was a recent meta-analysis of this that showed no difference between oral and transdermal in terms of the glycemic parameters. But the problem was that there were a lot of other differences they didn't see, like LDL, which tends to be 15% or so lower with estrogen. And so I'm not sure that that was powered enough to see a difference. And I'm a big fan of diabetes prevention. So that's a factor in favor of hormone therapy to my mind, and perhaps also to oral, although transdermal might be able to do that. We just don't have enough data yet. I wish we had more data on the transdermal, the long-term, large population randomized trial data. We just don't have enough of it yet.
So to summarize some of the points we've discussed this evening, the presence of pre-existing hyperlipidemia does not increase cardiovascular risk from hormone therapy when used to treat symptomatic women under 70. So in initiating therapy in a woman under 70, the important thing is that we want to manage her symptoms, and pre-existing hyperlipidemia or heart disease should not exclude her from therapy. There's no difference in cardiac event rates for women on hormone therapy as long as their dyslipidemia is appropriately managed. In women who have hypertriglyceridemia, we may prefer to use transdermal estrogen over oral, as the oral estrogen can increase the triglycerides. Blood pressure and other cardiovascular risk factors should be optimized prior to initiating hormone therapy. And overall, the decision to initiate hormone therapy should be based on symptoms. Cardiovascular risk should not exclude any woman from treatment, but should be appropriately managed beforehand.
Hormone therapy is obviously the most effective treatment for menopausal symptoms. We do have the non-hormonal, but they're not as good. They don't do as many things. They certainly don't touch things like osteoporosis. Estrogen alone is associated with a decrease in CVD risk. I showed you that. E plus P is not. However, that may be adverse effects of medroxyprogesterone, synthetic progesterones. But if you give them early, you'll have the best possible future for CVD. And of course, that's where we use it clinically. So much of WHI is completely irrelevant. Statins have the potential benefit. We talked about that. Addressing other risk factors, certainly important. As a woman goes through menopause, her risk of cardiovascular disease goes up dramatically. We've got to address all the CVD risk factors. Early discontinuation, there's evidence it may be harmful. So got to be thoughtful about that. Oral hormone thaeraPy lowers LDL, lowers Lp(a), the other effects we mentioned. Conjugated equine estrogen has the largest historical evidence in WHI. We haven't used it much recently, but it's got a lot of data. Estradiol is probably as good, but we're not sure because we don't have a lot of comparison between estradiol and CVD.
Eliot, I have to jump in here because we're
Oh,
hitting that clock. So
okay.
everyone else can
We
read.
got, we can you give me 30 seconds? I've got a minute on my watch. Estrogen patch, we talked about, very helpful. Synthetic MP, I think, is a bad player. Decision to initiate HT needs to be mainly for menopausal symptoms, and of course, has to be individualized for the patient. So, Guy, back to you.
Okay, thank you. I want to thank everyone for tuning in this evening to listen to this very spirited conversation, which can easily go for another hour. We have questions we didn't get to. We'll try to have our experts type in a few answers while we're here. I just want to remind everyone that the lipid panel is a monthly event. We're having our next lipid panel March 31st. That's going to be imaging and trying to characterize the atherosclerotic plaque. So I think everyone should join us then. And I want to thank Dr. Brinton, Dr. Katz, Dr. Wild, and Dr. Patel for a wonderful presentation this evening. And this presentation will be available at the NLA website at lipid.org, and the recording will be there for those that wanted to see the slides again or hear the commentary. So thank you again to our illustrious panel and everyone else. Have a great night. Take care.